Welcome, everybody. My name is Hervé Bacheles. I'm professor of clinical dermatology at the St. Louis University Hospital in Paris, France, and I have a great pleasure to chair this meeting dedicated to the transdisciplinary approaches in immune-mediated and inflammatory disease. For this, I'm joined by an outstanding faculty and by my co-faculty members, Professor Ian McInnes, who needs no introduction, but who's Vice Principal and Head of College of Medical, Veterinary and Life Science at the University of Glasgow, UK, an eminent and worldwide known expert in inflammatory rheumatological disease, and Professor Tim Orchard, Consultant Gastroenterologist and Chief Executive at the Imperial College Healthcare, the NHS Trust in UK. A few housekeeping notes before we formally start. First of all, please stay on mute for the duration of the meetings. You will be muted anyway. The questions to the speakers can be delivered through the Q&A function in the chat space. And you have any questions or are experiencing any technical difficulties, please use again the chat box. And we will try to address all the questions that you have during the panel discussion at the end of this meeting. This is the presentation plan. The understanding and clinical pathogenic pathways will be addressed by Professor McInnes. Then Professor Tim Orchard will put in place the rationale for an interdisciplinary management in inflammatory bowel disease. I will address the prototypic example of, again, a rationale for transdisciplinary approaches when it's for patient care, for research, for innovation, for psoriasis and emblematic immune-mediated and inflammatory skin disease. And we'll have a panel discussion which again will integrate as much as possible all the questions that you might have, and please be interactive. Please submit any query that you have. This is a unique opportunity for you to do so. And now, without further ado, it's again my great pleasure to introduce the first speaker, Professor Ian McInnes, who will go from bench to bedside to put in place the rationale for transdisciplinary approach, starting with the inflammatory pathways, which are pleomorphic across the different IMIDs. So Ian, the floor is yours.
Thank you, Hervé. Very kind of you indeed. Lovely to be here, to be spending a pleasant Scottish early summer evening with Tim and Hervé is always just a thing of joy. And of course, having the chance to meet with you all online, an absolute pleasure. My task is to set out the underlying pathogenetic rationale, if you like, for interdisciplinarity. There are many reasons to work together in the world, mostly because we like each other's company and because we bring cognate excellence and expertise. But actually, in the area of immune disease, there are also really strong pathogenesis and therapeutic-driven reasons to work together. So let's see if I can overcome the technical challenge of getting my slides to move over. Like Hervé, I am struggling. There we go. There we are. Well, these are my disclosures. Basically, I've had the privilege of working with a number of companies who make medicines in the area of immune-mediated disease, but I've also been grateful to receive funding from charities and the MRC in the United Kingdom. And this is Glasgow on a sunny day. Actually, funnily enough, this is the last time we had sun in Glasgow in 1993. So to have it, the coincidence of speaking to you when the sun is also shining in Glasgow today is not lost on me. So in the next few minutes, I want to talk mainly about the pathways that define the variety of immune-mediated inflammatory diseases. And I'm going to particularly set those pathways up that have turned out to be quite interesting targets across a range of different tissues. And then very briefly at the end, I'm going to set things up for Hervé and for Tim by just signaling what I think are red flags things that I'd like those who are in the derm and gastro world to be thinking about. If that's present in your practice, should I be involving a rheumatologist? And we'll tease that out in much more detail in my expert colleagues lectures, and then also in the roundtable discussion later on. So let's first of all think about what unites us. And as ever in life, there is far more that brings us together in the world of clinical medicine than there is that separates us. And this is a mythical pyramid in which I've placed in the center of the pyramid the idea of dealing with active disease, trying to aspire to remission, and of course the holy grail for us in the immune disease space, the achievement of cure. We're not there yet. There are some really interesting things happening in the field now, not least in the area of CAR-T and very, very deep levels of B-cell depletion. But I think cure for the vast majority of our patients remains a long-term ambition rather than something that we should reasonably thinking about in the context of current clinical care. Remission, on the other hand, is definitely something that we're all trying to get to, absent clinical disease, but often in the real world of our clinical lives, drug maintained. And I've thrown in here just the intriguing thought about comorbidity. That is the presence of other tissue involvements. And I'm going to emphasize that just in a moment or two to highlight why it's so important for us all. But I'm going to start with evolution. So what on earth is McInnes talking to you about evolution for? Well, one of the reasons why we have shared interests across the immune diseases in given targets is because the immunology of the world evolved not for the purposes of immune therapeutics, but rather there has been a sequential evolution of the immune systems as we become progressively further and further close to the higher end of the mammalian species coming from lampreys and sea fish and sharks. By the way, the highest known mammal species, just in case you were wondering, is the Scotland football supporter. This is the most resilient of all of the higher mammals, which has over many years been evolved to cope with the ultimate in the highs and lows of supporting a soccer team who have found more ways of losing, usually at the last minute, with the ultimate in disappointment. So that is, of course, therefore the most resilient immune system of all, the Scottish soccer team. But of course, as we moved into higher mammals, so too the necessity for the ability of our immune systems to deal with complexity. And the complexity necessary for host defense is why, at least one of the major reasons why we have immune disease at all. Now, to frame our discussions, I want to lay out for you the concept of private and public pathways. Let me start with the abundantly obvious. That is pathways that are public, that are expressed across immune disease tissues and have therapeutic tractability. And the most obvious one will be TNF-alpha, and I'll highlight that for you momentarily. Although we're starting to learn about other public pathways, for example, the IL-23p19 pathway and one or two others. Private pathways, on the other hand, are those that are potentially still variably expressed across tissues, but they have therapeutic utility in a smaller part of the spectrum of diseases that we call immune-mediated inflammatory diseases. And these are, for example, think of IL-6, not an effective target in psoriasis, but a highly effective target in rheumatoid in GCA. So we start to see more selective therapeutic utility, but that is not to say, by the way, that these pathways may not be expressed in the tissues of a range of diseases. It's just their hierarchical importance is adjusted. And one might ask why that was. Well, if we take an evolutionary perspective, there should be no surprise that the underlying genetics of immune disease will have something to say here. And this is actually really very nice review published 3-4 years ago, but still, I think, pretty contemporary. And for those of you wanting to read in a bit more detail, I commend this to you. But what the authors did was to pull together a range of different genes associated with immune disorders. In this case, you'll see a range of IMIDs, inflammatory bowel disease, rheumatoid, psoriasis, PSA, what I will be terming psoriatic disease, Hervé will expand on this later on, but also axial spondyloarthropathies, but also for added measure, SLE, type 1 diabetes and the like. So what this paper defines for you are genes that are associated with different pathways, enzyme regulation, catalytic activity, but also genes that are commonly associated across a range of immune disorders. So evolution requires shared responses, and therefore the likelihood as immune disease develops, the shared responses necessary to integrate host defense will bleed through, if you like, into the pathways that drive immune disease, but there will still be unique elements across different tissues. This has led to a convergent approach to understanding pathogenesis. And this is convergence because as clinicians, we like convergence, don't we? We like things to be one compatible with the other. We like to impose order on what may actually be underlying disordered systems. That's something that's worth thinking about. But what I've done here is this is mainly focused as a, for example, on psoriatic disease, on axial disease, but actually many of these pathways are implicated in inflammatory bowel disease. We can talk about that in discussion if you wish. But the concept that a variety of inducers, altered gut or skin, microbiome, for example, responses to mechanoinflammation, think the ileal ligament around the ileocecal junction in Crohn's disease, think the impact of metabolism and particularly of obesity across all of our diseases, and other environmental factors, for example, smoking. I can certainly touch on that in discussion later. But these have inducer factors, inducer cells that progressively lead to direct effector biology. And across all of our diseases, the effectors turn out to be macrophages and stromal cells working in an integrated way around the tissue of interest. But upstream, we have a contribution from stroma, from the adaptive immune system, and so on and so forth. Now, just a brief digression into the world of tissue purpose. This may feel a bit like stating the obvious, but right up front, if you've got that evolutionary perspective, the immune system has evolved quite differently in the skin or the GI tract from that response that is permissible in a so-called sterile tissue. Think the eye, think the axial enthesis, think the synovial membrane. And so, although we have the same background genotype in an individual, the same background epigenome reflecting their life experiences, their environmental exposures, their diet, their socioeconomic status, educational status, evolution dictates that individual target tissues will probably confer subtly different, but potentially rather important therapeutic pathway responses. And we, with Stefan Siebert and Orly Nam, we tried to pull this together in an essay we wrote just a year or so ago, which defines common triggers across immune diseases, a range of different target tissues, which will express hierarchical dominance for a given pathway based on the evolutionary imperative. So skin actually can tolerate quite wide surface area involvement, not complete surface area involvement. Erythroderma is a very dangerous state for hemodynamic stability and in fact confers mortal risk. But in general, the skin and the GI tract can tolerate a wider surface area of inflammation than, think, the anterior compartment of the eye. And that impacts evolutionary impact in different tissues of what I would call function permissible immune responses. And that in turn leads to different relationships with the wider comorbidities of disease. But we're increasingly recognizing common pathways, public pathways, if you like, in comorbid risk in terms of risk to the liver, risk of both obesity inputting and obesity consequent, and cardiovascular, and so on. Okay, I want to give just a little emphasis to obesity because there's a horrid paradox that has come through in the last 5 years. We've actually been pretty successful across the immune diseases in generating new therapies and improving outcomes, and we should celebrate that. But I'm Scottish, so you can't allow me to celebrate for too long without feeling just a little bit negative. You know, that's the Scots for you. I'm already thinking about the likelihood of rain tomorrow, even though the sun is shining today in Glasgow. And one of the consequences of our patients living longer, living better with immune disease, and being better treated by the whole range of biologic and targeted synthetic disease-modifying drugs available to us, is that the likelihood of comorbidity developing, and particularly the comorbidity of obesity. And so one of the paradoxes of our successful therapeutics is that we're now having to deal with the so-called state of multimorbidity, defined quite specifically as the presence of 2 or more chronic conditions in one individual. And regardless of those, they will confer a poorer outcome in either incident disease. That's really important. And so we're going to have to deal with comorbidity in our thinking as we think about the pathways across disease going forward. Okay, so if you could advance to the next slide, please, that would be grand. What I want to do now is just think a little bit about what I'm going to call pivotal cytokine nodes. And I've highlighted from again, an essay that George Shep, Marcus North, and I wrote now about 4 or 5 years ago. But I have to say, I think the fundamental concept of looking at common pathways and how those in turn might define the molecular nodes that offer up immune diseases, ultimately, by the way, with the ambition to take away the current nomenclature, and I'll come to that just at the end of this short lecture. But you can see here that there are a range of cytokines. And if we start at the bottom, TNF, I think, is a common effector cytokine. It's both a product of and an inducer of activation of macrophages, of polymorphonuclear cells, and have direct effects on stromal cells exemplified here in the fibroblast. But that could, for example, be an enterocyte, it could be a keratinocyte, it could be a tenocyte, and so on. You see moving up here that there are additional effector cytokines. In rheumatoid IL-6, I mentioned not particularly an effective target in IBD or psoriatic spectrum disease, but IL-17A, IL-17F have increasingly been recognized as pivotal downstream effector cytokines. The IL-17 family, actually, the ultimate in synergistic activity, and IL-17A and IL-17F work quite well with TNF, inducing synergistic effector responses. And then moving further upstream into the arena of immune regulation, interleukin-23, and in a historical term also interleukin-12. But I think we now understand that IL-23, defined by the presence of the P19 polypeptide subchain, is one of the master regulators that sit upstream in many immune diseases. And depicted here, a role in ulcerative colitis, Crohn's disease, inflammatory bowel disease, psoriatic disease, axial disease. Interestingly, no role as yet shown for IL-23 in pure axial disease, nor for that matter in rheumatoid arthritis. Again, this concept of public and more private pathways emerging. Okay, so if we can look at the next slide, a little detail on 1 or 2 of these cytokines. I'm going to focus mainly on TNF, on IL-23 and the IL-17 family, and brief mention of downstream signaling, and then I'll move to more clinically relevant matters. But I would, of course, and wouldn't I as an immune biologist, argue that these clinical pathways that are wrought by TNF have turned out to be really highly effective as therapeutic targets. So TNF is the leukocyte activator, endothelial keratinocyte activator, tissue cells, keratinocytes, enterocytes, osteoclasts activated by TNF. The acute phase response, a feature variably of different immune diseases, and nociceptor gating, pain, which is a huge problem, actually not just in arthritis. IL-23, I've already introduced to you the concept of IL-23 as an upstream regulator. In this slide, I'm depicting the cytokine structure, P40, P19, remember P40, the shared polypeptide with IL-12, P19, the unique polypeptide that defines IL-23 and the target of a number of therapeutics, thinking about guselkumab, risankizumab, tildrakizumab, and molecules that are exquisitely selective for IL-23 and will leave IL-12 signaling intact, binding to a heterodimeric receptor and leading to signal pathways. I'll come back to these, but note JAK2 and TYK2 just in your recollection of this slide. And IL-23 sits as an upstream regulator of the downstream driving cytokines 17A, 17F, TNF, in turn leading to activation of critical cells in the skin, in the joint, and the gut. And you can see here as you look across this figure, in the skin, activation of keratinocytes, fibroblasts, macrophages, in the joint, osteoclasts, chondrocytes, dendritic cells leading to upstream amplification, potentially of autoreactivity, and in the gut, colonocytes, epithelial cells, enterocytes, goblet cells, and undifferentiated epithelial cells, starting to think about differentiation pathways that can lead to altered healing and altered molecular basis for IBD perpetuation. So IL-23 sits upstream of the IL-17 superfamily, and I'm pulling out here particularly a role for 17A and 17F. Thus far, 22 certainly has an effector role, but less clear whether it confers therapeutic advantage. The same argument true for GM-CSF. Those approaches to GM-CSF or GM-CSF receptor alpha inhibition were mainly tested in rheumatoid and unfortunately didn't succeed at phase 3. The 17 GM-CSF receptor targets failed at phase 2, I have to say, so we don't really know the phase 3 answer there. But 17 and F have indubitably shown bioefficacy in psoriatic disease, but interestingly not in inflammatory bowel disease. And I will touch on that just in a moment because it tells us something about inherent balance in the immune system. And finally, focusing on this because of the therapeutic utility, I think all of you in this audience will be familiar with the range of cell modification factors that exist just adjacent to the membrane, so-called proximal signaling pathways, best known of which is the JAK superfamily, JAK1, JAK2, JAK3, and the unfortunately named but biologically beautiful TYK2. TYK2 was actually discovered before the JAKs, and its association with JAK family membership came later, so it had a different name, but it is a family member right enough. And you can see that different combinations of JAKs will assemble around the proximal membrane structure of the receptors for a whole range of cytokines of interest, not least in the context of this discussion, type 1 interferons and IL-23, IL-22. Okay, a quick comment on balance. Why so? Well, first of all, I've introduced the concept of immunological balance, which is adjudicated and adjusted by evolutionary pressure. And for that reason, I want to remind you that there is an inherent equilibrium in the immune system defined not by immune therapeutics, but by evolutionary pressure. So the type 1 responses, you used to hear people talk about Th1 cells. I prefer the phrase type 1 responses because in fact, there's more than a Th1 cell, there's a Tc1 cell. There are also innate lymphoid cells that will have type 1 responses. They're responsible for intracellular, viral, bacterial, and some tumor responses. Type 2, the classic Helminth response, but now implicated in the clinician's mind, at least in the context of allergy, atopic dermatitis, asthma, and the like. Type 3 responses, well, that's the IL-17 family with the upregulatory IL-23 pathway sitting in oversight as a master regulator, and again evolved for extracellular organisms. And there's a clue in the evolution here, particularly fungal responses. And of course, that's what we've seen, particularly with 17A and dual 17AF inhibitors, a fungal signal, exactly as we would have predicted. Less relevant, the IgA TGF-beta pathway for purposes of today. But this matters. And so, for example, we know that there are juxtapositional pathways that do not lead to the same intended clinical beneficial outcome when targeted in different tissues. And I'm highlighting particularly the yin-yang of IL-17 blockade in the intestine on the left and the joint, for which also reads skin on the right. Unequivocal evidence of beneficial effects of 17A, dual 17AF inhibition in the skin and in the joints of patients with psoriatic arthritis and axial SpA. But that's not the case when we block IL-17A in the gut, where there was no beneficial effect. There are indeed those who said there was detrimental effect. I think that goes a little further, but we can have that debate maybe at the question time. But certainly no evidence of benefit when 17A was inhibited in people with inflammatory bowel disease. So this is an expected outcome, ladies and gentlemen, not an unexpected outcome. Sometimes people say, oh, we were surprised to find out that. Well, I think that's a misinterpretation of the cytokine literature, to be honest. And turning now to the concept of therapeutic value from all of this pathway exposition. We've gone actually reasonably quickly in a couple of decades from an era, half a century ago, when the best we could do were broad spectrum immune modifiers, some of which had pathogenetic rationale. Actually, a long time ago, Nana Svarts late 1940s, talked about immunomodificatory capabilities of sulfapyridines and others, and sulfasalazine. And although probably for the wrong reasons, who knows, maybe the right ones, thinking about the gut microbiome, which wasn't called the gut microbiome in those days. Gold, penicillamine, methotrexate, anti-cytotoxic, cytoproliferative drugs. And they had their role. And of course, methotrexate, at least in rheumatoid and to some extent in psoriatic disease, has had its place. There was an era of failed biologic intervention, particularly in T-cell depletion. And then, of course, the advent of cytokine blockade. The pioneering medications targeting TNF, followed closely thereafter by a whole range of biologics targeting molecules of great interest to us, followed on in the early teens with JAK inhibition. And we can now summarize those effects in a whole range of immune diseases with extracellular targets generally mediated via biologic inhibition. Although, watch this space, there's lots of interest in smaller molecule extracellular cytokine and cytokine receptor inhibition. We're seeing examples of that, particularly in the IL-23 family inhibitors. Watch this space, very interesting work going on at phase 3. Or we target the actual membrane, and you can see some of your favorite membrane targets on the slide here, particular interest in rheumatoid and IBD, or through CD20, CD19 for target cell depletion, or intracellular targets. And again, JAKs, PD4, less so BTK as it's turned out in clinical trial world. So as I promised just a few moments ago, the proposition, I think, in front of us, ladies and gentlemen, is that these molecular pathways successfully targeted, but particularly by exquisitely selective extracellular biologics, might force us to move to signature cytokine concepts. In other words, the identification of public and private pathways is no longer a rather interesting conversation for rheumatologists, but in contrast is now something that we need to think about in terms of defining molecular signatures that in turn select patient subgroups for therapeutic intervention. We're not quite there yet, but we're definitely on that journey. Okay, so if we're on that journey, a logical consequence is that a new discipline is born. In my own view, it's not only just been born, it's well into its early adolescent years, but that's a personal view, and I'm looking forward to hearing what Hervé and Tim have to say about that as a slightly provocative concept. But at least the disciplines of rheumatology, gastroenterology, and dermatology are already working together. Some of us in shared clinics, some of us in shared practice, all of us in shared decision-making for all of the evolutionary and I think quite compelling immunological reasons I've laid out. And so before handing back to Hervé and Tim, I wanted just to think about a few red flags. Listen, I'm a Scottish guy, so of course it's a red golf flag, had to be. And these are just things to be thinking about. It's not a comprehensive list. Tim is going to show you a comprehensive list. That's the difference between a really careful gastroenterologist and a somewhat dilatory rheumatologist. But these were the highlights I wanted you to bear in mind. Joint pain is incredibly common. Joint tenderness even more so. Joint swelling a little less so until you're in your 50s, 60s, when actually primary nodal osteoarthritis is incredibly common and quite complicating for evaluation purposes. But if you're seeing dactylitis, nail changes, flexural psoriasis, if you're seeing daily variation, doctor, I'm really, really stiff in the morning when I wake up, pay attention. That's a little red flag that there might be something more than a little bit of post-sport or a little obesity-related tenderness, joint discomfort. And in that context, think about talking to your rheumatology colleagues. Think of the value of imaging. And particularly in rheumatology, we use ultrasound and MRI extensively now to help to separate true inflammation-related articular disease from other contributory factors. The presence of axial pain, spinal pain, especially associated with early morning stiffness in younger people that is unresolving, sometimes responsive to non-steroidals, although in the IBD field, we'll come to that later, probably not one of your diagnostic tests, please. Chronicity, if it's there for a long time, it really shouldn't be, particularly in younger people. The pattern of involvement, structural alterations, Fibromyalgia, secondary sensitization syndromes, does not cause structural deformity. That should be a huge red flag that something is not quite right. And of course, and now I'm speaking to the converted, dermatology, GI colleagues are very, very familiar with the patterns of musculoskeletal involvement, and that inherent knowledge will drive your thinking. Anemia is another red flag for me, and Tim will come back to discuss that momentarily. So that, ladies and gentlemen, is the, if you like, the red flag shortlist for a rheumatologist to his colleagues in the new field of imidology. And with that, ladies and gentlemen, I'm going to thank you ever so much for your attention. I hope you are familiar, refreshed memory, I'm sure, of the critical pathways that are both publicly contributory across the immune diseases, or more privately so in different subunits, subgroups, which eventually we'd like to define as cytokine signature disorders. And I hope that that gives a very clear explanation as to why we do have common purpose. We have common pathways, and that requires us to think together about decision making, and hence the need for those red flags that should prompt those common discussions. Professor Hervé, to you, sir. Thank you very much for your attention.
Thank you so much, Professor Ian. Thank you so much, Professor Martinez, for this amazing introduction. I don't think there can be a better introduction, really in depth and dealing with all the canonical, but also private, like you said, inflammatory pathway, which are engaged and differently across different patient subsets. And now, again, without further ado, it's again my great pleasure to introduce Tim Orchard, who will address and go more in depth into the really it's a sister family group of disease for several inflammatory disease in the skin field. In dermatology, and these are inflammatory bowel disease, and I could say the same for rheumatology. So thank you, Tim, for addressing the very important example of inflammatory bowel disease, what could bring the transdisciplinary approach. The floor is yours.
Thanks very much, Hervé, and it's always one of life's real burdens to follow Ian when he's been speaking, because you know you're never quite going to hit the heights that you've just heard. However, I will do my best as a mere gastroenterologist. I did some years ago write down as part of a book chapter all of the extraintestinal manifestations that I could find that had ever been reported in inflammatory bowel disease, and this is the list. I'm not sure it's completely exhaustive, but as you can see, a lot of registrars have written a lot of case reports over the years. But of course, we do know that there are very strong associations we've just heard between the gut, skin, and the joints. Right the way back as far as Barbara Ansell back in 1958, who noted that there were inflammatory arthritides associated with inflammatory bowel disease that were inflammatory, but actually not generally erosive. And of course, it's become very clear since then that there are associations between different immune-mediated inflammatory conditions, and how you look at these often depends on which organ system that you start from. So if you start with the best organ system, inflammatory in the gut, obviously, you think of things as extraintestinal manifestations. But it is interesting that you've got a 7.5 times chance of developing immune-mediated comorbidity in inflammatory bowel disease compared with non-inflammatory bowel disease patients. And these are, I guess, the commonest. The ones in red are ones which tend to run a course independent of the underlying gut disease. And that's important, of course, in terms of treatment, because they are more likely to need specific treatment. So axial spondyloarthritis, more likely to need treatment independently, but actually the oligoarthritis very often occurs with active bowel disease. Get the bowel disease under control, the arthritis will settle down. Similarly, erythema nodosum tends to be associated with active disease, whereas pyoderma gangrenosum and hidradenitis suppurativa, actually the link is much less clear. But of course, if you flip it around the other way, IBD is one of several extra articular manifestations of spondyloarthritis, along with acute anterior uveitis, some quite significant cardiac abnormalities, and psoriatic disease. And of course, there is an association of both overt inflammatory bowel disease, but also microscopic gut inflammation, which you find in a very substantial number of patients with spondyloarthritis. And there is an interesting, I guess, symmetry to this. So if you look at patients with axial spondyloarthritis, you see that inflammatory bowel disease is reported in about 10% of patients. But if you look for subclinical gut inflammation, then that can be found in up to 50% of patients who have axial spondyloarthritis. And anterior uveitis, of course, can be linked with ankylosing spondylitis and indeed subclinical bowel inflammation. If you flip it around the other way, axial spondyloarthritis is reported as an extraintestinal manifestation in up to 15% of patients who have IBD. But if you go looking for it in the same way that you can in the case of spondyloarthritis, doing colonoscopies on random people, if you do MRIs on people who have IBD, you'll find symptomatic spondyloarthritis in about 18%, but radiographic sacroiliitis in up to 30 or even 40 or sometimes 50% of patients with underlying inflammatory bowel disease. So both clinical and subclinical gut inflammation occur in spondyloarthritis, and both clinical and subclinical spondyloarthritis appear in IBD. Pyoderma gangrenosum is a skin condition, obviously, that occurs in about 1% of IBD patients. If you flip it around the other way, IBD is present in about 30% of pyoderma patients, and hidradenitis suppurativa, again, about 1% of IBD patients, and about equal number of HS patients. So given there's that sort of relationship between the gut and the joint, what can rheumatologists and gastroenterologists offer the patient by working together? I think there's something about, as Ian described, recognizing the things that would point to an additional diagnosis. And of course, the point of doing that is to get earlier diagnosis of the second condition, and also to coordinate treatment that is much more tailored to the individual patient who's sitting in front of you. So if you think about, is it important? Well, yes, late diagnosis is important because it can affect outcomes. So if you look at spondyloarthritis, we know that diagnostic delay in actual spondyloarthritis is associated with worse disease activity, function, spinal mobility, and indeed radiographic damage. And if you don't treat early, then there is an increased likelihood of radiographic progression. Similarly, in IBD, the long diagnostic delay results in increased frequency of bowel stenoses and therefore the need for surgery, particularly in Crohn's disease. So you often see patients who actually, by the time the diagnosis has been made, when they've got underlying spondyloarthritis, they're actually very close to needing surgery. So if you can bring that diagnosis forward, you will potentially save that patient an operation. And we also know that anti-TNFs are more effective in the early stages of inflammatory bowel disease than later on. Interestingly, gut inflammation is also a prognostic factor in spondyloarthritis, the giant cohort. So you have a higher risk of progression to formal ankylosing spondylitis, more bone marrow edema, and a higher risk of developing Crohn's disease if you start with microscopic gut inflammation. And you can see that here. If you've got acute inflammation, there's not a great difference, but evidence of chronic histological inflammation in spondyloarthritis. Okay. There we go. Whether or not gut inflammation was present was strongly linked to whether or not you needed to have an anti-TNF. And you were much more likely to need to have an anti-TNF if you had gut inflammation. Interestingly, and this is a relatively small number of patients, but it's still quite suggestive, if you did have gut inflammation, you were actually more likely to respond to an anti-TNF. So clearly, both from the point of view of the underlying natural history, but also the response to treatment, earlier diagnosis is clearly an important thing, and identifying whether or not you've got coexistent IMIDs. So what are the clues for underlying GI inflammation? In some respects, this isn't rocket science, but it's amazing how often when you see these patients, these indicators have been here and not picked up. So a family history of inflammatory bowel disease, the clinical symptoms of diarrhea, abdominal pain, rectal bleeding, weight loss are all important, and as is a persistent fever. The history or evidence of perianal fistulae or abscesses, anemia, particularly iron deficiency, but also anemia of chronic diseases, I think is an important thing potentially. And then also, if you've got a patient who's got inflammatory markers that are higher than you would expect them to be, given the level of inflammation from their underlying spondyloarthritis, think there might be something else going on. And it's quite difficult sometimes because young people particularly have a significant likelihood of having irritable bowel type symptoms where they can have rather variable bowel habit and diarrhea, or indeed constipation. And so you need to be able to try and work out how to focus on the patients who really do have inflammation. If you flip it around the other way, and Ian's talked about this earlier really, if you think about spondyloarthritis, that low back pain, morning stiffness, restriction of lumbar movement, the anterior uveitis, the peripheral oligoarthritis, all signs that you might have an associated spondyloarthritis with your IBD. So if you want to try and work out whether a patient's got genuine gut inflammation, inflammatory bowel disease, compared to whether or not they might have irritable bowel syndrome, a good screening test is in fact a fecal calprotectin. Because we know that clinical activity poorly correlates actually with endoscopic activity, but Calpro is quite a good marker, particularly actually in colonic disease. And this slide shows you that it's a good non-invasive marker for inflammatory bowel disease. There is an elevation even when Crohn's and ulcerative colitis are in remission, and a very marked elevation when they're active. It's worth noting the very, very wide interquartile ranges in Crohn's, and that I think is related to the fact that it's much better at picking up colonic Crohn's than it is in picking up small bowel Crohn's. So it's a good screening test, and if you take the low cutoff of 50, then it has an incredibly high negative predictive value. You have to be slightly careful with it because non-steroidals can obviously trigger a level of gut inflammation which can be picked up by the Calpro, and the within-day variability of fecal calprotectin is quite significant. But if you have a patient who's got a definitively negative value despite non-steroids, it's a clear indication they're very unlikely to have IBD. I guess it's just worth noting that you might start off with a patient who's got IBS symptoms and they look completely fine, and you've done a Calpro and it's negative, but of course there may be a change. So if there is a change in those symptoms, it's worth repeating the calprotectin. And of course, if you want to make a definitive diagnosis, then for Crohn's disease of the small bowel, you can see here a significantly inflamed segment of terminal ileum. And small bowel MRI is a very good diagnostic modality, and of course a colonoscopy for ulcerative colitis. So if you've made the diagnosis, what actually are the treatment implications? As Ian described extremely eloquently, essentially, there are clearly similarities between these immune-mediated inflammatory diseases, but there are important differences that, of course, then have consequences for your choice of therapy in individual cases. So if you can get good coordination of treatment between the disciplines, then you can make sure the patients get the most appropriate treatment and indeed dose, because there are dose differences between spondyloarthritis and inflammatory bowel disease with some medications, particularly anti-TNFs. And also you can think about whether a combination of treatments is required for the particular circumstances for an individual patient. And as the armamentarium of drugs gets wider and wider and wider, I think there will be more and more occasions where we end up, particularly in very difficult cases, using combinations of treatments to target different parts of the inflammatory cascade. This is a summary, which I'm afraid is very UK-centric, and it's also very inflammatory bowel disease-centric, to be honest, of different modalities and what they're currently licensed for use in the UK. And as you can see, the anti-TNFs are widely available for the whole range of immune-mediated inflammatory diseases. Etanercept, however, is not licensed for ulcerative colitis and Crohn's disease, and I'll show you the data that that's based on. Essentially, it's a fusion protein, and of course, therefore has a subtly different mechanism for inhibiting TNF. The IL-12/23 inhibitors and the IL-23 inhibitors, which are good for the skin and the joint, interestingly, but as Ian alluded to, in axial spondyloarthritis, don't appear to work. And similarly, the IL-17 inhibitors that are good for skin and spine, but less effective for inflammatory bowel disease. And then, of course, you've got some very targeted drugs, particularly the integrin receptor antagonists, which are pretty gut-specific, and then the JAK inhibitors, which again are useful across a wider range. So just going back to those things, these are your likelihood of flaring if you're treated with various types of TNF inhibitors. And as you can see, infliximab and adalimumab are associated with a low rate of flaring compared to placebo, but actually etanercept is associated with quite a significant rate. And if you looked at the trial data for etanercept, this is a reflection of the original trial data for that drug. The IL-17 inhibitors are interesting in axial spondyloarthritis. You can see pretty effective drug. But for Crohn's disease, and secukinumab is the top line here. It's the black dots, and this is the Crohn's disease activity index. So obviously lower is better, and you can see the placebo, which is the dotted line, gets a lower general CDAI than secukinumab. So although they're not actually that far away, and obviously the confidence intervals overlap, there's clearly no benefit to using IL-17 inhibition in Crohn's disease in this trial. And then similarly, if you flip it around the other way, the IL-23 inhibitor, so this is for ustekinumab, which is an IL-12/23 inhibitor, so it's a P19 inhibitor. You get a pretty decent response in Crohn's disease. The top dose you get about approaching 60% response. But again, you look across to ankylosing spondylitis, and I'm sorry, I did chop this chart off slightly in order to get it onto the slide. But you can see that in the primary endpoint and pretty much every secondary endpoint, there is literally no difference between placebo and those who were treated with ustekinumab. So those two classes of drug, you need to think carefully about how you're using them. And the other thing is that the dose that you may require can be different depending on whether you're treating for spondyloarthritis or whether you're treating for IBD. So we know that just from a sort of prescribing perspective, higher loading doses of adalimumab are required, 160/80 versus 80/40. And the dose of infliximab is higher, 5 milligrams per kilogram rather than 3 milligrams per kilogram. And we escalate the dose very frequently. And one of the things that is very notable in inflammatory bowel disease, and you can see this on the right, as this is what your CRP does, depending on what your adalimumab level is. it's pretty closely related. And we know that for people who've got very severe Crohn's disease particularly, getting a high level of anti-TNF is a very effective predictor of response. So, practical tips in terms of rheumatologists for gastroenterologists and gastroenterologists for rheumatologists. Again, perhaps not rocket science. Non-steroidals should be avoided in patients with IBD. They definitely have a tendency to make things worse. If you take a good GI history, that will help you to identify patients. That don't forget actually to ask, because that is the first step to making a diagnosis. Think about your biologic carefully. Etanercept is not probably a sensible option. Think about your dosing for anti-TNFs and don't use IL-17 inhibitors. There is a suggestion that you can flip from 5-SA to sulfasalazine for patients who've got IBD and also a spondyloarthritis. For gastroenterologists treating patients with IBD who may have spondyloarthritis, you need to be mindful of the risk of osteoporosis actually when you're prescribing steroids. Hopefully we are prescribing many fewer steroids than previously. Again, think about asking the question. We did a study many years ago looking at MRI evidence of sacroiliitis and inflammatory bowel disease, and it's generally thought that most patients are asymptomatic. In fact, when we took a detailed history and performed the BASDA and BASFI scores on these patients, you could identify nearly 2/3 of patients on the basis of their clinical symptoms alone. So it is worth taking a good history, even if you're a gastroenterologist. And then think carefully about the utility of joint injections, particularly for the sort of oligoarthritis that you quite frequently see in inflammatory bowel disease. So back to what can the gastroenterologists and rheumatologists offer each other. I think that interplay in terms of getting the diagnosis earlier and getting the right treatment is incredibly important. How do you do it? I think it depends on your local circumstances, but I think there are some fairly straightforward but important principles. And there is virtually no evidence for which specific solution is correct, so it has to be pretty empirical. You need to have a situation where you've got easy access to real-time opinions between GI, rheumatology and dermatology. It's probably very helpful to have local protocols for how to investigate and treat patients who have more than one immune-mediated disorder, so that actually you don't have to start from scratch every time you see a patient who's got back pain in your IBD clinic. If you've got a big centre, then clearly you should have a workload that will make it worthwhile to have an interdisciplinary immune-mediated disease clinic. And obviously, as somebody who's clearly very interested in the pennies in terms of the efficiency of running a health system, you'll need to think carefully about what that critical mass is. But even if you don't have a formal clinic, actually, if you can arrange yourself so that you've got co-location of your gastroenterologists and your rheumatologists and your dermatologists in terms of where they're physically doing their clinics, then you can actually allow real-time access to opinions just through the fact that you can nip from clinic room to clinic room. And with that, I will hand you back. Thanks very much.
Thank you, Tim. That was, I think, absolutely compelling following Ian's introduction and with the different inflammatory pathways. And hopefully, I guess that my task is to use, again, one prototypic example of immune-mediated and inflammatory skin disease, one of the most prevalent worldwide, psoriasis, which affects roughly 2% of the general population worldwide, and to see how basically this example fits with the private versus public inflammatory pathways and why we need immunologists, like Ian alluded to, in the IMID centers of some kind. Okay, these are my disclosures. Okay, so to make a long story short, in a highly prevalent disease like psoriasis, and we can discuss, referring to what Ian elegantly presented and alluded to the evolution process and how basically IMID might have been selected positively across the ages following some pandemia and everything. We can discuss that later with an example that I picked. But what is really prominent as on the daily practice is that mainly or even quasi exclusively for what we call severe psoriasis based on the requirement of systemic therapy. That's how it is defined. This is a proxy, but it reflects the severity of the skin disease. There is an overprevalence of different comorbid conditions, starting with the cardiometabolic high risk profile. That's why cardiovascular ischemic disease is overprevalent in this setting, but also will of course will save a very special stages for psoriatic arthritis. I will denominate as PSA because this is not really for me a comorbidity, but rather an extracutaneous inflammatory comorbid condition with a very specific status because it has some commonalities but also some differences with psoriasis. So there is a link between the two, but they are not a copy and paste of each other. And of course, there is overweight and obesity. There is inflammatory bowel disease to some extent, anxiety and depression, addictions, and this is can be summarized in this cartoon. But I guess that many of you are aware of that. I attract your attention and really I warn you against the really sort of reflex to really believe, and that's for me so far is a belief that the skin inflammation and the skin vessels inflammation is fueling the inflammation in the other organs, extracutaneous organs. We don't have any demonstrations for that. We could even argue that in many cases, you could have very severe PSA, psoriatic arthritis, in patients with very mild psoriasis. So there is a complex relationship between the skin inflammation, the skin vascular inflammation, and for instance, the coronary heart inflammation in atherosclerotic disease and so forth and so on. We can discuss that in the panel discussion later if that's a wish. Okay, maybe it's better that you move on the slides. Next slide, please. So the dermatologists, and thanks to the how we were taught and bred by our rheumatologist friends and colleagues, we learned that we were in sort of gatekeeper or at least detection position. Which is one of our missions, because in most of the cases that the skin before the joints, and so all the dermatologists and even the GPs and all specialists engaged in the management of patients with psoriasis should learn the list of very simple questions to ask the patients, making sure that we will not overwhelm our rheumatologist colleagues with some patients who are obviously not affected with PSA or suspicion of PSA, but with gout, with other joint disease that are also prevalent in this setting. But there are some common pathogenic markers. I will get back to that later. And especially in the genome-wide association studies showed that there are some protecting loss of function variants in the type 1 interferon system, and also that obviously the IL-23, IL-17 axis is playing a role in both synovial and also skin inflammation at the population level to some extent. Again, private, public, that's the debate. Next slide, please. The risk of psoriatic arthritis increases with the duration of psoriasis. There are some skin disease characteristics which are increasing this relative risk to develop PSA when you have the scalp, gluteal involvement, and flexural lesions and nail lesions. Well, basically, you have, according to the skin presentation, a relative risk which is significantly higher. But the bottom line, I guess, is that PSA can appear and may appear at any moment during the course of psoriatic disease or psoriasis, I would say. Next slide, please. The last but not the very least, I mean, and I'm speaking under the control of Ian, but not all joint manifestations in psoriasis are psoriatic arthritis. Even this kind of deformation and phlegm in these young patients with neonatal onset, very severe psoriasis, refractory to several lines of therapies, even biological therapies. These patients has no PSA, but he has all the characteristic of what is called the JAK hand or JAK arthropathy, which is a characteristic which is mainly seen in the context of connective tissue disease, Sjogren's syndrome, lupus erythematosus, and others. And so that's very interesting to see, and I will get back to that later, that there is a subset of patients with psoriasis that might well have more that might be underlined by some pathway which have something to do much more with lupus than with the classical IL-23, IL-17 driven psoriasis. And that's very interesting because, again, like Ian evoked, that's really pleading for stratification. And I guess that's one of the really fil rouge of my presentations. Next slide. So another important matter is we hear a lot about early intervention. I will again speak about that very soon. But you heard about some preliminary but retrospective single center study, in this case the group of Verona with Paolo Gisondi and Giampiero Girolmoni, showing that according to these cumulative incidence rates of psoriatic arthritis in the patients with skin psoriasis, when they compare the patients treated with phototherapy with those with biological DMARDs, there is a substantial reduction in the group in the dotted line, representing the patients treated over 8 years with different lines of biological DMARDs, a reduction of the risk of PSA. So you could say, seeing these cumulative incidence rate curves, this is the half empty, half full cup, because you don't annihilate this risk, and that's very likely to be due to the fact that it's yes, we have to plead and to support early intervention, but the question is, in a given patient, to have a tailored approach and to identify some biomarkers that we are cruelly missing for now, who is the best candidate for TNF-alpha blockers, for IL-17 blockers, eventually for JAK inhibitors or TYK2 inhibitors in this case. So that's really, these are very important questions. Early intervention, yes, but early tailored intervention, we don't know how to do that for now, but I'm absolutely convinced that this is a way to go and that we will go this direction very soon. Next slide, please. So regarding inflammatory bowel disease, but Tim already alluded to that, and so I will be quite quick. It came as a surprise when we started to treat the patients with psoriasis with IL-17 blockers. We saw a sort of outbreak, not so many cases, but especially in some studies with ixekizumab, and also quite mirroring what happened in one placebo-controlled study with brodalumab, which is an IL-17 receptor antibody, where in this case, Tim referred to the secukinumab placebo-controlled trial, which was not completely conclusive, but suggestive for a detrimental effect. In the case of brodalumab, there was a detrimental effect on the course of IBD. So the program was canceled. And this came as a surprise because but again, I'm speaking under the control of Tim, and the mucosa is full of IL-17 producing T cells. So this is to say that not because you have a lot of IL-17 releasing cells in, let's say, the coronary arterial ducts in the case of arteriosclerosis, in the mucosa for IBD, means that the IL-17 has the same function and might have both a pro-inflammatory role, but also a sort of a functional barrier role in the case of inflammatory bowel disease, and that was also suggested by some murine models of IBD with all cautious address with respect to the human disease. But to get back to this slide, what is clear is that, especially in the patients with severe psoriasis plus psoriatic arthritis, if we go for the fully adjusted incidence rate ratio, you have the lower boundary of the 95% confidence interval, which is by far exceeding the one value, because it's in this case 2.36 for psoriatic arthritis. Severe psoriasis, it's close to 2, and severe psoriasis in hospital as well. So why for mild psoriasis, it's basically not conclusive. So there is no evidence that in patients with mild psoriasis, they would have an increased risk of inflammatory bowel disease. And this is true for Crohn's disease in the case, but also for ulcerative colitis. So there is a relationship, and I will get back to that later, because there is recent evidence that there are some genetic and immunogenic pathways which are engaged and that might be shared across the two diseases. Next slide, please. Okay, and this is also, I will go very quickly through this French National Health Data System database epidemiological study against the patients unexposed to apremilast but newly exposed to any IL-17 inhibitor, basically in multivariate Cox analysis. The hazard ratio is 3.9 against the lower boundary is around 2. So there is what was seen by Alexander Egeberg in the Danish population at the previous cartoon, in the Danish global population, in the registers, the Danish registers, which are covering the whole population, is also true in other geographic setting in the more restricted but also population level. Next slide, please. So very quickly, but fatty liver disease and also liver abnormalities are very prevalent in these patients with severe disease. Up to 35% roughly of the patients admitted for severe psoriasis, they have abnormal liver tests. And of course, underlined by a myriad of different liver conditions, and that complexifies the use of methotrexate in these patients, because, as you know, one of the risks, the two main risks to develop liver fibrosis in the patients with psoriasis under methotrexate is not the individual dosing, is not the cumulative dosing of methotrexate, but it is basically an underlying liver disease, and also the BMI, the body mass index, because it's a confounder for fatty liver disease. It's a risk factor for fatty liver disease, precisely. Next slide, please. So we need some interactions with gastroenterologists, hepatologists in practice, and this also to mirroring what Ian said for the overweight and obesity. Again, the following, the incidence and prognosis of psoriasis and psoriatic arthritis in patients who underwent bariatric surgery, again, in the Danish population. You can see that the adjusted hazard ratio of PSA were 0.29, so clearly with the upper boundary of the 95% confidence interval, which is 0.71, 71, and basically 0.53 for gastric bypass and gastric banding, respectively. So there is evidence that following management of overweight and obesity, there might be at least a relieving of overweight as a risk factor, both for PSA and for psoriasis. Next slide, please. So now another concept which is happening a lot in practice is the immunological switch, which has been denominated as yin-yang of the immune system, following the TNF-alpha inhibition, but it happens to a lesser extent following IL-17 inhibition, where we observe some paradoxical skin reactions. Sometimes I have to say I've seen a couple of patients with paradoxical joint disease as well, including actual disease, and I would like to hear from Ian about that. But for paradoxical psoriasis or psoriasis-like eruption, that's 2 to 5% of the patients with another IMID receiving TNF alpha inhibitors, mainly within infliximab, and I would say that IBD are the risk is increased in IBD compared to patients with inflammatory rheumatological conditions. And this is due to the fact that there are several factors engaged in this immunological switch. But to make a long story short, in psoriasis, in classical psoriasis, or assumingly, there is a type 1 interferon response which is engaged at a very early phase of the plaque formation, and then the type 1 interferon signature is supposed to be lost. In the case of paradoxical psoriasis, the type 1 interferon signature remains and is really the hallmark, a critical feature, and really the main driver, if you wish, of the paradoxical eruption. You can easily understand why we see more and more reports of JAK1 and TYK2 inhibition very successful in this setting. And the other thing is that because you have only 2 to 5% of the patients developing this condition, there should be some genetic biomarkers, other biomarkers. And so there is a lot to do to identify the patients who are at risk to develop these paradoxical eruptions. Next slide, please. But what is really fascinating, and we thought in our group that would happen one day or the other, is that this paradoxical psoriasis, that even the best derm hesitated to call that psoriasis, but in some cases it's really psoriasis. They have a type 1 interferon signature which is really chronically engaged. And what is really interesting, there is a groundbreaking paper that has been published in Nature in 2022. In this case, it's not paradoxical psoriasis. It's all psoriasis and other IMID conditions. And what the group of Jean Bilili in Stanford found, he analyzed, reanalyzed the genome-wide association studies data, confronting with the RNA-seq data from different tissues, from the blood, and basically, he identified a sort of canonically engaged pathway, which in this case is the type 1 interferon pathway, or rather, alteration is what is called RNA editing alteration. So RNA editing is a very subtle and very discrete process with the substitution of one nucleotide by the other, which prevents that the endogenous RNA becomes immunogenic. And if you have this system which is altered, you have what we call an interferonopathy, and the MDA5, which is an RNA sensors encoded by the IFH1 gene, which is a gene which has been associated with psoriasis, but also psoriatic arthritis and the other IMID conditions, basically is engaged unwittingly. And you can see that several IMID conditions, they are a part of the irritability is accounted, this alteration of RNA editing and the engagement of the type 1 interferon pathway is accountable up to 20% in the case of psoriasis, but also in inflammatory bowel disease, rheumatoid arthritis, multiple sclerosis, lupus. So this and type 1 diabetes. So some comorbid conditions in the context of psoriasis, but also what we can, figure out is that there will be at some point a new taxonomy of immune-mediated and inflammatory disease, because these cases are, and we don't know yet, but are probably, to be treated with some type 1 interferon or dual inhibition, but targeting the type 1 interferon system. Next slide. And the great thing is that this is validated not only at the population level. Well, this is a subset of patients, not all patients. The majority of the patients with psoriasis, they are responding to the scenario operating through IL-23, IL-17. This is dominant. It's not to say that type 1 interferon pathway is dominant in all patients with psoriasis. But the nice thing is that when you have a model, a single gene model, which is validating what we observe at the population level, in this case, there are some mutation, in a gain-of-function mutation of the RNA sensor encoding genes, IFH1 and DDX58, leading to syndromic psoriasis, very severe, and accompanied by some Jacu-hand arthropathy or other joint manifestation, but also aortic or coronary calcifications, valvular insufficiency in some cases, and also chronic keratitis or glaucoma. In short, comorbid conditions belonging to an interferonopathy spectrum. And I think that's something that we should reanalyze in the patients with psoriasis, all sorts. Next slide, please. So one of the, of course, to wrap up, this shed new lights on the attrition of drug survival in psoriasis over time as a proxy for secondary loss of efficacy, because most of the patients switch from one biologic to the other in psoriasis. This is because of insufficient efficacy. And when you see this bad beer, the UK registry in patients with psoriasis coordinated by Catherine Smith, Richard Warren, and Chris Griffith, you can see that the curve over 2 years, where there is the best survival rate, is for guselkumab. That's one thing. Be cautious, because this is at a time that guselkumab was the last drug approved. But you can see for all the IL-17 blockers and also the TNF-alpha inhibitors, an attrition up to 25% of the patient after 2 years. So for some poorly immunogenic or non-immunogenic drugs, it's impossible to believe that this loss of efficacy would be only explained by immunogenicity. Yes, it happens for adalimumab, infliximab, for the TNF-alpha blockers, but very unlikely to account for the attrition of efficacy for the others. So we need to understand in all IMIDs why there is a loss of efficacy. Is that due to immunological switch? Is that due to alterations in PK and PD? That's really something that we are going really blind for now. Next slide. So in short, there is a broadening diversity of the targeted treatment in moderate to severe psoriasis, and we can answer to virtually all the situation. But the question is, at the time, next slide, please. At a time that we can reach some optimal clinical response, and that early intervention is heavily promoted, My answer is, okay, early intervention to reach complete clearance, yes, but how and for which patients? So again, precision medicine should be part, I think, of the immunologist debate. And with that, last slide is really very practical. Is really to put the center in the center the patient. Sorry for the typo. And that's the interaction with between, of course, rheumatologist, gastroenterologist, and dermatologist. And make no mistake, I mean, the dermatologist is not to underestimate the power of dermatologists, that it's at the bottom, or I don't consider the dermatologists at the atlas, you know, kind of weighing on their shoulder all the burden of IMIDs, but really that with humility, having really for the benefit of the patients, but also for to favor the advances in research, consistent and very strong bonds and interactions to understand why this is successful in one case and not successful in another case as a tailored strategy. And with that, I would like to thank you for your attention. So I guess that I'm not sure that we have well, thank you, David Robin, for your great comment. Thank you for this great program, Hervé, Ian, and team. That's really great. Maybe we can start the discussion with getting back to Ian concept of private versus public. Ian, you have one cloud of mystery for us as outsiders, that why IL-23 blockade is unsuccessful in patients with actual disease. And this is very consistent. Why there are some models, including murine models, where IL-23 is really playing a role in actual spondyloarthropathies and spondylitis. So that's really one of the burning questions that I had for you.
Yeah, sure. Thanks. Great question. It's a commonly asked question. Now, my dear mother and grandmother brought me up to be honest and just to tell the truth. I don't think we know the answer to that question right now. So let me start with that as the summary. However, as ever in life, there are possibilities. The most commonly proposed explanation is that in the axial skeleton, for whatever reason, probably something to do with mechanotransduction and the way the immune system evolved in areas of very high local biomechanical stress, there's a substantial contribution from the innate lymphoid compartment. And one of the interesting things about pure adaptive Th17 cells, to use the old nomenclature, type 17 cells, one of the interesting things is that there are probably pathways that drive downstream effector cytokines like IL-17A, 17F, TNF, IL-22, that there are pathways that drive those independent of IL-23. And those have been described in the axial skeleton, particularly beautifully described by Dennis McGonigal and his colleagues in Leeds in the UK. But there are other really quite helpful data that are quite consistent with that. So the idea might be that there are actually bypass pathways in the spine that allow, as a reflection of the particular anatomical site demands made of the axial skeleton, that allow bypass, and so pure P19 inhibition is insufficient. Now, that's a reasonable explanation, but it does leave out the fairly obvious problem that, well, hang on a minute, these innate lymphoid cells turn up in other tissues in which IL-23 blockade is successful. And so I think we probably also need to give consideration to tissue access, to tissue dominance, possibly to time to response. And I would remind you that there are studies ongoing. There are indicative, very interesting indicative studies where people have looked at axial symptomatology in P19 inhibitory trials in psoriatic arthritis. And just to those outside the rheumatology discipline, there is a debate in rheumatology as to whether pure axial spondyloarthritis, in the olden days we called that ankylosing spondylitis, it's now a syndrome of pure axial spondyloarthropathy or radiographic axial disease, where there's an MRI abnormality but maybe not an X-ray abnormality. And there are studies in which those patients have been compared, and people are trying to work out, well, is pure axial disease the same as the axial disease that occurs in people who have psoriatic disease? And I think that's an open question. And it might be, who knows, in the long fullness of time, we'll find that a P19 inhibitor actually does confer benefit. We get signs of that from post hoc sub-analyses, but they are fraught with danger. Because remember, if other bits of you are getting better and you are a patient report, and those questionnaires that are applied in complex trials are not necessarily focused on a primary axial outcome. So I think there's a yin, there's a yang. Watch this space. And I think we as an immunobiology community are challenged. I don't think we've got a good enough answer to your question, Ivy. I have to say that.
No, that's absolutely great. Thank you, Ian. My second question is for both of you, Ian and Tim. I mean, it's very bluntly, do you believe that joint disease and AS, psoriatic arthritis, let's pick these two for the joint disease field, and for Tim, the inflammatory bowel disease, for Crohn's disease on one hand, and UC on the other hand. Do you believe that these entities are several diseases, right? Meaning that there are some, group of patients that obey to substantially different, let's say, inflammatory scenario as a matter of hierarchy of the inflammatory players. Because, in the skin, we found a lot of IL-17 in palmoplantar pustulosis, and IL-17 blockers, they don't work. So it doesn't tell you that this is the main driver. So my question for you is, do you think that we have to stratify the patients? And the second question is, how do you foresee the tools to do that in a close and more distant future? That's challenging, but maybe Tim, you would like to start first?
I was rather hoping you wouldn't. I think it's a very, very difficult question, isn't it? Because I think that the problem is, if you are measuring something and it is common, and you have high concentrations of it, that does not equate to its biological effectiveness. I mean, I think there's an interesting. If you compare the P19 inhibitors and the P40 inhibitors in terms of IL-23, I mean, the concentrations of IL-23 are probably many, many times smaller than the concentrations of IL-12, and you mop up a lot of your IL-12 with sort of things like ustekinumab, and it's so the much greater concentration of IL-12 is irrelevant. It's the small concentrations of IL-23. So I think there is a real issue about understanding what is driving inflammation in any given scenario. And I think that certainly in inflammatory bowel disease, there is an eternal question about are Crohn's disease and ulcerative colitis different things? Is isolated colonic Crohn's disease different from ulcerative colitis? Interestingly, if you look at some of the if you look at some of the immunology, some of the autoantibodies, you see serologically, you tend to see P-ANCA, you see in ulcerative colitis and colonic Crohn's, you tend to see ASCA in small bowel Crohn's. They are immunologically quite similar. If you look genetically, again, some of the more straightforward HLA associations are very similar between isolated colonic Crohn's disease and ulcerative colitis. Whereas, of course, you've got the NOD2 CARD15 associations with small bowel Crohn's disease. But certainly when we looked at the microbiome and the metabonomics associated with the microbiome, actually there do appear to be differences between isolated colonic Crohn's disease and ulcerative colitis. So I think there is a very complex interplay in terms of the pathogenesis between the underlying microbiome, the the genetic background of the host sort of immunostat, which is in terms of how the intestinal immune system is actually functioning in an individual, that then defines disease phenotype.
Great, thank you. Ian, you want to add something for the future of stratification of patient, and also maybe requalification of bringing in a new taxonomy of IMIDs? Is that really worth going there? Keeping of course the clinical pathological entities alive, but bringing the molecular pathways that you very nicely exposed in this taxonomy. That would be I guess the wrap up.
Very much so. You're reading my mind, Hervé. So first of all, I think Tim has really beautifully elaborated the reasons why at the moment we have different names for these diseases. Actually, I think your question cuts to the very philosophy of what a disease is going to be called in the next 20 years. It used to be cancer, then it became esophageal cancer, then it became breast cancer, then it became breast cancer that was BRCA, and then it became colon cancer that was that had a given mutation. Well, if we learn from that, there's a reason, of course, that we have classification of disease. First of all, it allows trialing to take place on roughly the same kind of disorder in different parts of the world. Secondly, a diagnosis allows a clinician to make a decision. If we could classify people with a range of immune-mediated disorders such that that decision that the clinician makes is more likely to yield a positive outcome for the patient with less risk, then the original diagnostic name will be discarded and replaced with a new name that makes a better decision for the patient on the basis of the clinician's reflection. So actually, we're not ready for that yet. But the question and this whole concept of public-private pathways eventually is going to challenge the whole idea of whether we have a named disease or an actionable molecular signature. We're not there yet for the record, but that's what I think many of us hope we'll get to. I've kept that succinct because we're almost out of time, but I hope that's complementary to what Tim has just said.
Oh, absolutely. I think that would be a great conclusion. Maybe, Tim, you want to add, but please, because I'm under pressure of, we have to wrap up.
I just wanted to sort of reinforce, I think that's absolutely right. If you think about where we've come from, certainly in inflammatory bowel disease, we've started with the sort of names, and then we've moved, we started to really effectively clinically phenotype stuff. So we used to think about Crohn's disease as Crohn's disease. Now we really split Crohn's disease up into small bowel Crohn's disease, large bowel Crohn's disease, and ileocolonic. And the treatments are different. We know that how you investigate them is different. We know that, as I was saying earlier, calprotectin is good for large bowel, less good for small bowel. And the next step has to be, how do you then move that into a more molecular and pathogenic disease classification, which will allow us, because at the moment, in being gastroenterologist, there's a slight element of finger in the air when you decide which biologic treatment or which advanced treatment you're going to use. And of course, we've got to find a classification, as Ian says, that helps us to guide therapy, and ideally, as you were saying, personalize the treatment for the patient.
Yeah, thank you. I guess we are dealing with the same issues. Again, thank you both. That was really a great panel discussion, and I hope the attendees enjoyed it. Next time, please don't get shy. Don't submit any query, any questions. That's really a unique opportunity to do so. I would like to thank everyone for attending. Your feedback is really important for us. You should please fill the short evaluation form that will show up after the end of the conclusion. And the live stream version of the webinar will be available to be on the IMID forum and the YouTube channel very soon as possible. And would like to thank our sponsor, Johnson & Johnson, who did support this activity through an independent educational grant. Again, Ian, Tim, it was a great pleasure to really have this meeting with you. And for all of us and also all the attendees, don't forget the Immune-Mediated and Inflammatory Disease Forum. You have here, you can register at the imidforum.com or scan the QR code, which is showing up here. There are several languages, more than 700 slide resources, courses available, congress reviews, more than 20,000 members, and 300 podcast episodes. So this is really something, and we have to be grateful to the CSIS medical team and Callum and his amazing team. So thank you again, and hope to see you soon for a new adventure in imidology, to quote Ian. So that was really a great moment. Thank you all.